Okay, so patient care delivery models. This is pretty important stuff, and we will see various types of these when we go out and do clinicals, when you get hired as the nurses. Every area of the country has different preferences, but you can see all of these pretty much everywhere. So, what's the first type? Total patient care or private duty. Total patient care, private duty. Says exactly that. You are one-to-one with that patient. It's you. Only you, nothing else. You provide all the cares that shift. This could mean working in a home or working in a clinic or a hospital. But you, the nurse, one nurse, one patient. You do it all. Now, a lot of nurses love this. Why? Because you know that everything will be done correctly. You don't have to rely on anybody else to get anything done. You don't have to wait for your partner to help out or a CNA to come in and do something. It's you. What's the downside? It's all you. So that can be demanding, but it works. And so that's total care or private duty. And I'm going to kind of make a tally over here. It's one-to-one, right? Total care is one-to-one. Functional nursing. Functional nursing. This breaks nursing care down into a series of tasks performed by a team. Generally, a team will be an RN, an LPN, and a CNA. So, in this situation, in a situation like this, each person performs specific functions. The CNA, baths, vitals, feeding, see, those kind of things. LPN passes meds, some teaching. RN, all assessments. MD, communication, coordination. So, each task has a specific person responsible for it. What's the good side for this from the patient's point of view? Well, from the patient's point of view, there's almost always somebody with that person. So you very rarely you don't go very long without seeing another person to help take care of you. That's nice. At the same time, you're constantly having somebody come in and take care of you. So it can result in fragmented care. It can be quite impersonal. You know, they come in and you just perform the same tasks over and over, and it does get sometimes monotonous. And patients, while they like having frequency of care, it's not always the most happy. It also can result in lack of accountability for the total patient. I mean, the RN will say, well, the LPN will do the meds, so I don't have to worry about that. And the LPN says, well, I don't have to help with vital signs and feeding because the CNA will take care of that. So there's less, while it's a team, there's less teamwork. Okay, so functional. Divide by task. Functional is dividing by task. Next, we're going to talk about team nursing. What is team nursing? Similar to functional nursing, where you have an RN leading a team, there's a team here also led by an RN. But in this case, you might have an RN. Wow, I can't spell RN. How do you spell RN? Might have an RN like that. So you have, let's go like this. You got a manager, RN manager. And then you have team A with RN leader. And then you have another RN, maybe an LPN, maybe a CNA. Over here you got team B, RN leader. And maybe this time you have RN, CNA. It can be different every time. And then you have, say you have 12 patients, and here you have 10 patients. Or again, team nursing. You have a team leader, you have their people underneath there, but now, instead of CNAs just bathing, and just meds, and just assessing, you might have specific patients assigned to each of these people. This is what we did when we did that assigning client care assignment. So that's team nursing. It is probably the most common, at least right now. There's almost always a team conference at the beginning of the shift, coordinating all this, but generally the team leader is the only one that gives report to the others. So at the change of shift, you've still got these people providing cares, whereas the RN leader is off giving report. So there's better handoff between shifts that way. If you have good communication, this is great. If you have a good leader working with a team that like each other, this is great. However, if you get a leader who's not good or team members who aren't good, it can be a nightmare. Team nursing. RN-led teams. It's different than functional nursing because remember, functional nursing, you divide up the work by tasks. Here you divide up the patients, you divide up the tasks by the patient. You assign patients to different people. Primary nursing. Primary nursing, what does that mean? This is a little different. Here you have the RN and you as the RN are responsible for the cares of the patient for a 24-hour period. That does not mean you are working for 24 hours. It means you are responsible for that 24-hour period. You may have, within your ability, you have a day shift RN, a PM shift, and a night shift. You've got CNAs day shift, PM shift, none on nights. You've got a respiratory therapist. You've got all that. You are responsible. You're also the only person that communicates with doctors. So if something goes wrong, that person goes to you, you go there. You know everything that's going on for that patient. You coordinate all the care. Now this results in a lot of continuity of care for the patient because you have one person who is the hub of everything else going on. It also requires the most management skills. Therefore, this is the kind that many nurses do not like. A lot of nurses are not comfortable managing people. They don't mind doing the work. They don't like telling other people what to do. In this case, this RN has to be confident in all of the other RNs that they will get the job done right, because that person is not going to do it. This person might be primary for a half dozen patients or more. So they have to delegate and follow up and be confident that the work will get done. That's all management. So primary care is manage, delegation. Management and delegation. Last one is patient-focused care. Patient-focused care. This brings nurses back up to the higher level, not quite the management level here. You have an RN. You have an RN who is taking care of, who's delegating and managing cares, but also provides cares. So you're making sure that the CNAs and the LPN, and maybe your co-nurse, are getting stuff done, but you're also providing cares on your own patient. So this is probably the most popular and most preferred type. So patient-focused care is caring. I gotta learn how to spell. Plus management. Total patient care. You do everything with total patient care. Functional, you do a specific task. That person does a specific task. That one, in team nursing, you're responsible for a team of nurses. And you coordinate and delegate and just follow up. Primary, you are in charge of that patient for a full 24 hours. Everybody reports to you. You are in charge. You are the manager of that patient, and you may have a lot of patients that you are manager of. And in patient-focused care, you are working alongside others who are also doing their job. You're managing people and yet working at the same time. 5 types of patient care. And, you know, I know that you probably prefer one or the other. Everybody in this room probably has one that they prefer, one that they would really hate. Where do we see total care? A lot of times we see total care in the very high-tech, complex specialty units. Neonatal, critical care, women's health, ER. A lot of times that nurse does everything. That's it. They just do it all. In the ER, we didn't usually have a CNA. We sometimes did, but not usually. We did everything. Working in the critical care unit when I did that, we sometimes had a CNA, depends on what shift it was. But most of the time, it was either me with one patient or me with two patients. A lot of times they would give us two patients. We'd sit at the doorway so we could look in both rooms, keep an eye, which is sometimes got a little psychotic at times trying to figure out what's going on with the two people. I've worked on team nursing. I've worked on patient focus care. Never done primary nursing. I like, you know what? I don't like functional. I don't. I think, to me, in my mind, that's too fragmented, too much. I'm only doing one thing. I'm not doing anything else. I don't like that. I like total care in the right situation. I would not want to do total care on a med-surg unit with 6 patients. Team and patient-focused care are my preferences. All right, this is a short segment. We're going to come back. What's after this? Oh, we're almost done. Yay, we're almost done with the first half. So, staffing is important. They've discovered, hold your horses, I mean, this is going to get exciting, but they've discovered that hospitals that have lower levels of staffing have more adverse outcomes. Go figure, fewer nurses, more problems. Also, higher acuity patients have more responsibilities, which increase nurses' workload. Seriously, somebody had to pay a study for that? And those of you that work in hospitals, you see that the patients are getting sicker before they get admitted. They're older and they're sicker, which means much higher acuity, much greater chance of a problem happening. And as nurses, we're responsible. Yay us. Things like pneumonia. Remember we talked about ventilator-acquired pneumonia? If you can avoid pneumonia, or let's say you don't avoid pneumonia, pneumonia can add up to $28,000 to that hospital stay. $28,000. Now, here's something to do with talking about that. You know, we're trying to avoid VAP. We're trying to avoid catheter-acquired UTIs. We're trying to not have adverse drug effects, pressure ulcers. Those are called never events. And with a never event, let's write this down because this always seems to surprise some students. With things, let's talk about a CAUTI, catheter-acquired UTI. We want to avoid that. The reason why we want to avoid that is A, it's bad for the patient. But B, what's this entire lecture all about? Medicare, Medicaid initiated it, and then insurance companies followed suit. If a patient develops a catheter-acquired urinary tract infection while in the hospital, Medicare, Medicaid, and insurance companies will reimburse the hospitals nothing. They will give nothing to the hospital because of that happened. Because that happened because of the hospital. Hospital practices caused that illness so that they say they don't have to pay for it. And I don't really disagree with that. A person that gets a UTI because we put a catheter in incorrectly or left it in too long, that's our fault. That's why very frequently, before the catheter goes in, they will do a UTI, they'll do a UA looking for that UTI, because if the person has a UTI before the catheter goes in, no problem. But if they're clean first and then they get the UTI, CAUTI costs about $8,000. Seriously. With increased length of stay and antibiotics, it's about $8,000. And that's out of pocket from the hospital. Hospital will not get any money for that. Doctors won't get paid for it. VAP, we just saw, is a $28,000 hit. So if you can avoid 1-2 VAPs a year, you've saved $56,000 for your hospital and kept 2 people healthy, which will make your hospital look better, which will get better survey results. Could you get an RN for $56,000 a year? Oh yeah. Full-time, 40 hours a week, $25 an hour is $1,000 a week. $52,000. Save 3. You save 2 VAPs and 10 CAUTIs. Now you had $136,000. That'll cover the cost of an RN. The other thing with reimbursements is Medicare is now reimbursing based on customer satisfaction scores. Let's call them what they are, customer satisfaction scores. Better scores get a higher reimbursement rate. I kind of have a problem with that. This is opinion only. Who is most likely to submit a survey? A person who is really happy with their results, people who got what they wanted and they're fine with it, or people who are really unhappy. The extremes. The really happy people will usually fill out surveys. The people who got what they wanted won't. People who are really unhappy will all fill out their surveys. You're going to get skewed results. To me, that's an unfair reason to change reimbursements. I can do everything possible, but I can't make that person be happy. When I worked in the ER, I got a bad review one time. They put in their survey that I refused to give them Vicodin. Now, first off, I don't have the authority to prescribe Vicodin. I am an RN. Second, I remembered the patient specifically. I was there when the doctor told the patient that the doctor was not going to prescribe Vicodin for this person because this person has had a history of Vicodin abuse and was only going to provide ibuprofen. The patient left AMA, but he complained that I wouldn't give him Vicodin, so I got a negative review, and that affected my raise that year. See, that's personal, but I have a problem with that. Work assignments. Work assignments, the way they are set up are going to vary from hospital to hospital, with acuity, with seasonal fluctuations, with everything. When I was a house supervisor, I was responsible for setting staffing levels. It was always based on how many people were in the hospital at midnight. You got to figure out a way to do it, but that doesn't, it's the way it is. And it's a challenge to find good staffing, because if you overstaff, you have too many people there, it's going to cost the hospital money. If you understaff, you're going to have overworked nurses who allow a VAP to develop. It's tough. It's a very difficult position. That's the end of this half of the lecture. Second half is going to be all on economics. Oh, it only gets better from here.